Good evening, everyone. I'm going to be presenting on behalf of my postgraduate here, and these are preliminary reports from the study that we're doing on a bigger scale. So this is a study to correlate the refractive error with dry eye in pediatric population. So dry eye is an important prevalent public health problem.
You are the chief author, you are the presenting
Yeah,
author.
yeah.
No, the study has been done
Done
by
by my
postgraduate, but
postgraduate.
she is, so we can consider for the award.
Yeah, I have submitted under my name. So dry eye is an important and prevalent public health problem, and we do find that nowadays children's tear film and ocular surface is being exposed to a lot of challenges like climate change, pollution, use of smartphones, computers, lack of sunlight exposure, and of course myopia treatments. So factors such as inadequate blink, inadequate refractive correction, poor sleep quality may also impact healthy children's tear film function. So when we looked at literature, there are studies which do show that there is a correlation between dry eye and refractive error in young adults, albeit at a very subclinical level. Smartphone using children also had a stronger preponderance with association with dry eye disease, and of course video display terminals use is an important risk factor for dry eye disease. There are also studies that talk about tear instability and worsening visual acuity and contrast sensitivity in children, and as high as 23.7% in school senior high school students. So against this background, we decided to evaluate the risk factors and correlation between dry eye and refractive error in a pediatric population. So we included, so the study is still going on. So we are presenting the data from 109 kids. Group 1, emmetropes and astigmatism. Group 2, simple myopia and myopic astigmatism. Group 3, simple hyperopia and mixed astigmatism. Age more than 6 to 17 years with good systemic health status. We excluded kids who had any ocular surface disease or any symptoms, corneal ectatic conditions, strabismus, children who don't cooperate, and other systemic diseases. So we included patients who came into our hospital based on the inclusion criteria. We divided into 3 groups, and we had 70 myopes, 34 hyperopes, and 5 emmetropes. So we got an informed consent and a patient information sheet from the patient and the parent, and we did a dry eye evaluation with the Schirmer's test. We evaluated the T-beauty, tear meniscus height, and the corneal staining, and also the blink rate. So when we put out our results, we had Schirmer's 1 test was 27.5 average for myopics, 28 for hyperopes, and 29.25 in the emmetropic group. The blink rate was found to be significant. We found 8.92 in myopes, 12 in hyperopes, and 9.23 in emmetropes. T-beauty was 11.52, 17 in hyperope, and 11.47 in emmetropes. What we did find, however, though there was a small clinical significance, statistically these values were not significant. And this is the correlation of the refractive error. You can see the refractive error. One thing that we did notice was the higher the refractive error, the worse the Schirmer's value was, and this is something that we found across all the parameters. So the worse the refractive error, the higher the myopic refractive error, the worse was the Schirmer's 1 value. The same went for the blink rate. We could see that the blink rate was much lesser for the high myopes, and also the same for the T-beauty values. So these are our preliminary reports, and we found that though they were statistically insignificant, clinically we did find a difference between them. So we are working on collecting a higher sample and presenting the factors. So definitely increased usage of smartphones, computers, they play an important role. Preventive measures and environmental modifications can reduce the risk of pediatric dry eye disease. Thank you.
Any working hypothesis you have why higher refractive errors children have lower blink rates or lower Schirmer's?
Sorry, sir.
So you said that when the refractive error was
higher, the blink rate
was lower.
Lower, yes, sir.
But any working hypothesis you have made why should that be?
Well, I think it's the other way around. Because of the lowered blink rate, the dry eye disease.
No. I'm saying why should, because if it is for myopia, it is understood that they are putting drops, or if it is myopia, they are watching terminals or they are seeing television or something like that. Why should it occur in hyperopia or astigmatism? It's not part of your study, but if you have any working hypothesis why this is happening.
Well, I don't have a working
maybe
hypothesis.
Next year.
It is. Yeah, I would. If I can work out something, definitely I'll bring it. Yeah, this is just an observation that we did find out, but we
But
need
it's
a
a
much
unique
higher sample
observation,
size
yeah.
in order to reach the statistical
How did you
significance.
calculate the blink rate?
So we kept on 1 minute, and then we asked the child. We just observed the child as they were seeing the waiting in the waiting area. We didn't tell the child that we were noticing them, but we had one person who was appointed to stay there and watch the child as they were waiting in the waiting area.